Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. In response to the COVID-19 pandemic, the United States government made several policy changes that established or expanded economic supports for Americans. In March 2022, Congress passed the Coronavirus Preparedness and Response Supplemental Appropriations Act, the Family's First Coronavirus Response Act, and the Coronavirus Aid, Relief, and Economic Security, or CARES Act. In addition to mobilizing a clinical response, these laws contain provisions focused on mitigating the negative effects of the economic recession, including provisions related to paid sick leave, income supports, nutrition assistance, and other programs. And then in 2021, Congress passed the American Rescue Plan Act, which was the COVID stimulus package, which had additional economic provisions, particularly an expansion of the child tax credit. We've long known about the link between economic health and physical health, but these new provisions give us an opportunity to gain even greater insight into the relationship between economic security and physical health. And it is out of this opportunity that arose the collection of papers that you're going to hear presented in today's event. They come from the November 2022 issue of Health Affairs, where we're looking at the health effects of economic security policies in place during the COVID-19 pandemic, some in place prior to, some put in place because of the pandemic. It's a really interesting collection of papers, and it's rare that we have an opportunity to have such insight into the direct relationship between economic policies and health. So I'm very excited to be able to explore those with you in the event today, and we hope you'll read more about them in the journal issue. Throughout the event, there's an opportunity for you in the live audience to submit questions using the Q&A right below where you're watching the screen. It's hard to weave a lot of questions in, but we'll do our best. Now, as we get started, I want to acknowledge the two foundations that supported this issue, the Blue Shield of California Foundation and the Episcopal Health Foundation. I'm going to turn to these two, to representatives of these two organizations to make a few introductory remarks. First, I'll turn to Rachel Wick, Senior Program Officer at the Blue Shield of California Foundation, where she leads the foundation's work to strengthen economic security and mobility for Californians. I met Rachel when she was at the Consumer Health Foundation here in Washington, D.C. She was there for 8 years. So Rachel, you and I go way back. After Rachel, you'll hear from Dr. Xiaoqi Sim, the Episcopal Health Foundation's Vice President for Research, Innovation, and Evaluation. He leads the work of the foundation in health policy analysis, research planning, and pilot projects to advance the strategic plan of the foundation. He's been the Chief Strategy Officer of the Charles B. Wang Community Health Center in New York City. He's had leadership roles at the Wallace Foundation and the Asian American Foundation. First, let me turn it over to Rachel.
Thank you, Alan. It's so nice to be here with you and the Health Affairs audience discussing this important issue. I'm Rachel Wick. I'm a Senior Program Officer at Blue Shield of California Foundation. And at Blue Shield of California Foundation, we identified before the pandemic that economic security needed to be a key strategy to achieve our mission of improving health equity and ending domestic violence in California. When you control for the cost of living in California, we have one of the highest poverty rates in the country. And for many families with low incomes, particularly communities of color, the daily struggle for survival is unrelenting and has been unrelenting even before the pandemic. We know that the COVID pandemic was devastating and heartbreaking for these communities in California and across the country. But I believe that a silver lining is that we saw bold and swift action to get money and resources into communities by all levels of government and private foundations, at times working in concert with each other. And we were proud to be part of that push, channeling our resources to many of the policies highlighted in this special issue, such as demonstrating the impact of unrestricted cash assistance and advancing policies related to paid sick leave. Ellen, I want to thank you and Health Affairs for spotlighting this issue and its connections to health. I'm super excited to hear from the authors today, and thank you to all who submitted and all who are featured in the issue. The timing of the release of this issue is critically important. There is unfinished business in federal policy, state policy, and local policy to take research like this and make permanent many of the innovations that were tried and we believe will be proven effective in the pandemic. And we also have to continue to make the case to the broader public about the connections between issues like economic security and health, connections that maybe this audience and as a longtime public health professional may take for granted. We are intrigued by some recent research by the Frameworks Institute on cultural mindsets that shifted in the pandemic. And one of them showed that there was a rise in systemic thinking among the general public, but that systemic thinking didn't extend to health. Many people still see health as an individual issue. And so I believe armed with policies and research like the ones that are featured in this issue today, we will make progress on meeting the needs of low-income communities across the country, and particularly communities of color, in gaining access to economic security and improving their health for the long term. Thank you so much.
Thank you, Rachel, and thank you, Alan. Yeah, it's an honor to be here. I'm Shao-Chi Sim at the Episcopal Health Foundations. We are Texas-based health philanthropy. We all know that good health requires more than medical care alone, and the COVID-19 pandemic dramatically show why this is true. As we all know, the pandemic continues to highlight how a continuing public health crisis hits those with the least resources the hardest, whether it's about working an hourly job that cannot be done from home or not being able to take time off to get a vaccine or test. The health and financial impacts of COVID-19 are not the same for everyone. And EHF research continue to show the significant pre-existing health differences for Black and Hispanic residents in Texas led to higher COVID-19 death rates plus billions of dollars of increased healthcare spending and lost work productivity. There's no doubt the human and economic cost of health disparities continue to grow during the pandemic, and we are only beginning to learn, the importance that, about how medical care alone cannot address this issue. This is the reason why our foundation proudly support this important health affairs thematic issue on the health impact of economic security policies. It is critical to learn how these non-medical strategies impacted health so that we are all more prepared for future pandemics, public health emergency, and economic downturns. With that, I will pass it back to Alan.
Thank you, Rachel and Shao-Chi. We're so appreciative of the support from your two foundations. And now let's move into the material for today. Whenever we have a theme issue or a group of papers, we find an advisor to help us navigate the topic, select the abstracts and papers, and invite folks who can write about the topic. For this group of papers, our advisor was Dr. Rita Hamad, and she'll be moderating the next panel where the authors of the papers will present their findings. Dr. Hamad is a social epidemiologist and family physician at the Philip Lee Institute for Health Policy Studies in the Department of Family and Community Medicine at UC San Francisco. She's the director of the Social Policies for Health Equity Research Program, associate director of the Center for Health Equity, a member of the steering committee of the UCSF Population Health Data Initiative, has been the policy lead for the UCSF Preterm Birth Initiative, and serves on and is incoming co-chair of the Communications Committee of the Interdisciplinary Association of Population Health Sciences. We've benefited from your advice and counsel, and now we get to benefit from your moderation. And Dr. Hamad, I'll turn it over to you for the first panel.
Great, thank you so much, Alan. I'm very excited to be moderating this session today. We have some great presentations lined up, summarizing a few of the papers in this themed cluster. Each presenter is going to be speaking for a quick 5 to 7 minutes so that we'll have plenty of time for the Q&A. For the audience, please do make sure to type your questions into the Q&A box. There's not a chat box for this session, and we'll try to get to as many as we can at the end. So without further ado, let's go ahead and jump right in. Our first speaker is Abdel Nasser Ali. He's a doctoral student at the Department of Health Management and Policy at the University of Iowa College of Public Health. And his presentation is entitled State Eviction Moratoriums Associated with Improvement in the Mental Health of People Who Rent.
Thank you, Rita. Hello, everyone. My name is Abdel Nasser Ali. Again, I am a doctoral student. And before I begin, I want to thank my co-author in this paper, Dr. George Webby, for his contribution to this work and for his advice over the last 3 years. So the title of our paper is State Eviction Moratoriums Associated with Improvements in Mental Health Among People Who Rent. Next slide, please. As a motivation for our work, landlords file 3.6 million eviction cases in a typical year. These evictions disproportionately affect Black and Hispanic renters. And eviction is a public process through the court system. And obviously there are adverse negative health effects that are linked to these evictions. Homelessness and financial hardships are some of those impacts on these evictions. So during the COVID-19 pandemic, the policy response to this were eviction moratoriums that were put in place at the state and the federal level. Some 43 states and DC put together eviction moratoriums, and then the federal government also put together 2 eviction moratoriums, first through the CARES Act in March of 2020, and then later on the CDC put together an eviction moratorium which began on September 4th through July of 2021. Next slide. So our research question is, what was the effect of state eviction moratoriums in 2020 on mental health status of renters? So the data we used for a study, we used survey data from Behavioral Risk Factor Surveillance System, BRFIS, in 2020. The outcome was days not in good mental health in the past 30 days. We also used an alternative measure of frequent mental distress, which was an indicator for 14 or more such days. We also, for our policy data, we used state moratoriums and other pandemic-related data from Boston University's CASP COVID-19 database. For our methods, we used difference in differences, sort of the triple difference design to compare renters and homeowners while leveraging state differences in moratoriums over time. We primarily focused on renters because they are the group that are most directly affected by these moratoriums. And then we included homeowners as a control group to capture within state time varying trends in mental health due to other events than moratoriums. Next slide. So the results shown here for our full sample and the 2 outcomes that we had, the number of days not in good mental health and the likelihood of frequent mental distress. The estimates show that there were 0.37 fewer days not in good mental health in the past 30 days among renters with those who lived in active state moratorium states. And then the other variable, the likelihood of frequent mental distress, the results show that the eviction moratoriums were associated with a decline in the likelihood of reporting frequent mental distress among renters by 1.3 percentage points. And then we also did a subgroup analysis by income, and then men and women, and then by race and ethnicity. And all those outcomes show decline in both the outcomes, the number of days not in good mental health and the likelihood of frequent mental distress. Next slide. So the implications for this study is that some evidence that the state eviction moratoriums were related to an improvement in mental health among renters. And the findings were consistent with two other studies that used different design and different data. The first study that also did analyze this topic, Ant and her colleague in 2021, found declines in likelihood of African-American families reporting anxious or down based on COVID-19 household per survey. And then this other study by Lafayette and her colleagues in 2021 also found that eviction moratoriums that block notices of eviction, which is the first two steps of the eviction stages, were associated with the lower likelihood of moderate or severe mental distress. And I think this overall is a suggestive evidence on the importance of housing security and related policies for health. So our study had some notable few limitations. We focused on only short-term effects. Obviously, data that was available at this time when we were doing this analysis, we only had 2020 data available. So the focus was just short-term effects. And then Burfess has only one mental health outcome. And so we evaluated just one mental health outcome. As far as future research possibility with this, we're trying to also evaluate the federal moratorium effect. And there were two federal moratoriums that were put in place, like I said earlier. So we're trying to look and see whether the federal moratorium also had an effect. We're also trying to look at the interaction between state and federal moratorium, whether there is some effect to that. And then we would like to separate the effects by enacting versus ending moratoriums. And so as far as that's what we'll be looking at for our future research. Next slide. So these are our references for these slides. Next slide. And then if you have any questions, my email is abdinasir-ali@uiowa.edu. Feel free to reach out. I'm so happy to be here and I'm thankful to Health Affairs.
All right, great. Thank you for that wonderful presentation. As a reminder to the audience, if anyone has questions, please do type them into the Q&A box and we'll get to them after all of the presentations are over. So next up, we have Dr. Emily Dorr, who's a doctoral student also at the Emory University. And she's going to be speaking today on easing cash assistance rules during COVID-19 was associated with reduced days of poor physical and mental health. Take it away.
Thank you, Dr. Hamad. Hello, everyone. My name is Emily Dorr, and I'm a PhD student in sociology at Emory University. I'd like to thank Health Affairs for this opportunity to present our work. Like Dr. Hamad just said, I'll be discussing our study, Easing Cash Assistant Rules During COVID-19 was associated with reduced days of poor physical and mental health on the behalf of my co-authors, Melvin Livingston and Paul Schaefer. Next slide. I'd first like to just acknowledge funding for this project from the National Center for Injury Prevention and Control. Next slide. So our study examines the effect of state-level changes in the Temporary Assistance for Needy Families program, or TANF for short, in response to the COVID-19 pandemic, and the effect these policy changes had on health of likely TANF participants. TANF is the primary cash assistance program in the US, and it served just over 2 million people in 2020. It was created in 1996 under President Bill Clinton and replaced Aid to Families with Dependent Children, or AFDC. Whereas AFDC was an entitlement program that responded to increased needs with increased funding, TANF operates under a block grant budget that has not increased its funding since its implementation. With the goal of decreasing welfare dependency and increasing employment, TANF uses several strategies that have shrunk the number of beneficiaries since 1996, including requiring participants to work to receive benefits, sanctioning non-compliant participants, and imposing a 5-year lifetime limit on receiving benefits. While it's a federally funded program, states have control over how it's implemented, which results in a lot of variation in benefit levels, eligibility criteria, and requirements for participation across states. In the early months of COVID, many state TANF offices responded to the unemployment crisis and the resulting increased need for financial resources by making changes to their programs, including providing extra benefits and relaxing administrative burdens. In our study, we focused specifically on 7 changes to state TANF programs likely to have the largest impact on health. Those changes were providing extra emergency cash benefits to people already participating in TANF, providing emergency cash benefits to low-income people not already participating in TANF, continuing to subsidize wages even if hours were cut or jobs were lost, waiving work requirements or granting good cause exemptions, waiving or pausing sanctions, automatically recertifying benefits, and not counting time on TANF during COVID-19 toward time limits. We hypothesize that these changes may affect acute stress-mediated health outcomes for likely TANF participants. Next slide. To examine this question, we used a triple difference design, like the previous presentation, to estimate the association between state-specific changes in administering TANF and individual health. The individual level demographics and health outcomes were derived from the Behavioral Risk Factor Surveillance System, or BRFIS for short, from January 2017 through December 2020. For the TANF policy changes, we built off of a list compiled by Justin Schweitzer of the Center for American Progress by adding start and end dates after an extensive online search for these dates. Since BRFIS doesn't ask about TANF participation, we identified likely participants as women with a high school education or less who are 18 to 29 years old with children in the household, since mothers with a high school education or less are the most likely to be eligible for TANF. The placebo group was women with more than a high school education in the same age range, also with children in the household. We examined 3 health outcomes likely to respond quickly to a change in economic and financial distress: number of mentally and physically unhealthy days, and any binge drinking, all within the past 30 days. We then compared changes in these outcomes pre and post the start of the pandemic between the treatment and placebo groups within and across states. Next slide. So in this forest plot, you can see the 7 policies that we examined on the left side as rows, and the dots are the point estimates for each of the health outcomes. So dark blue for mentally unhealthy days, red for physically unhealthy days, and green for binge drinking. The darkened dots with point estimates above represent significant findings. Of the 7 policies we examined, we found that 6 meaningfully affected the health of people likely to participate in TANF. Overall, we found that changes to TANF policies were protective of health and that they reduced the number of mentally and physically unhealthy days and reduced the number of people reporting binge drinking. For example, automatically recertifying benefits, the second row of the policies, resulted in 1.02 fewer self-reported mentally unhealthy days during the past month. Providing subsidized wages for cut hours resulted in a 4.4 percentage point reduction in the number of participants reporting binge drinking in the past month. And providing emergency cash benefits to those not already participating in TANF resulted in 0.25 fewer self-reported physically unhealthy days. We did have 2 surprising findings where policy changes were actually not beneficial to health that you can see on the right side of the plot. We elaborate a bit on this in the paper, writing that these findings should be interpreted with extreme caution since these changes appear to be driven by changes in the comparison group, whereas the other findings are driven by changes in the treatment group. Next slide. So to wrap up, our results show that relaxing TANF administrative burdens and providing extra cash benefits were generally protective of people's health during COVID-19. More generous cash transfer policies and reducing administrative burdens in the safety net programs can be powerful tools in reducing the negative mental, physical, and behavioral health responses to stress created by unemployment and wage loss. State TANF programs have shown that they can respond quickly and effectively to families' needs. Policymakers should consider whether these policy changes and flexibility should be made permanent to improve population health and decrease health disparities. Next slide. Thank you for listening, and please let me know if you have any questions during the Q&A. Thank you.
All right, great. Thank you, soon to be Dr. Dorr, for that presentation. Thanks to all the presenters for keeping in the time limit. Our next speaker is Dr. Elizabeth Ananat, the Malia Professor of Women in Economics at Barnard College, and she'll be speaking today on racial and ethnic disparities in access to pandemic-era unemployment insurance, implications for health and well-being.
Thanks so much for having me today, and to the audience, thanks so much for being here and listening. As Rita said, I'll be speaking about racial and ethnic disparities in pandemic-era unemployment insurance access, and this is work that is joint with John Fitzhenley II, who's a doctoral student in the Princeton Economics Department, Becca Daniels, a doctoral student at Duke University in the School of Public Policy, and Anna Gassman-Pines, a professor at Duke University of Public Policy and Psychology and Neuroscience. Next slide, please. So we're focused today on the effects of unemployment insurance on health and well-being. Previous work has shown that unemployment is harmful to both physical and mental health. It increases material deprivation and material hardship, and increases psychological distress. Other previous work has also documented racial disparities in the receipt of unemployment insurance upon the experience of unemployment. And additional work has documented that unemployment insurance can help buffer the effects of unemployment on health. All of this suggests that unemployment is harmful to health. It is particularly harmful to the health of people of color and minoritized populations, partly due to larger increases in unemployment during recessions and downturns for people of color. And the fact that UI often does not reach the very people who are worst affected by layoffs and by the experience of unemployment suggests strong implications for health disparities related to unemployment, and an opportunity for government to intervene to address that health disparity that is not currently being met by the type of unemployment insurance that folks have. Now, during the pandemic, unemployment insurance was expanded in ways that made a larger group of people eligible. So we look at a group of people whom during the pandemic, they have equal access to unemployment insurance under the law. That is, they should all be able to get pandemic-era unemployment insurance if they lose their jobs. This is a racially diverse group of folks who are otherwise similar. They are hourly service workers with young children in Philadelphia. Because they are hourly service workers, they particularly experience high rates of dislocation from employment during the pandemic. And because they are parents of young children, they're experiencing a lot of other stress during the pandemic. And so they are a very noteworthy population as sort of the nexus of a lot of health stressors that are occurring during the pandemic. So we're particularly interested in the experiences that they have with layoff and with unemployment insurance. In this research, we asked 3 questions. First, does unemployment cause similar harms to health and material hardship across race and ethnic identity in this relatively vulnerable population that is otherwise similar? Second, does receipt of pandemic-era unemployment insurance similarly protect workers across race and ethnicity? And third, are workers similarly likely to receive UI? Recall that they should all be eligible across race and ethnicity. Next slide, please. So our first finding is that, as previous research has shown, layoffs are harmful to material hardship and health during the pandemic. Layoffs during the pandemic strongly predict income loss for our sample, the inability to pay rent or mortgage, and psychological distress. They do not, interestingly, predict food insecurity, and that we hypothesize and develop more in the paper is possibly because of the strong supplemental food policy response that occurred during the pandemic that was targeted to families with children. Recall, all of our families in our sample are families with children. We also find and supplement the previous literature by finding that these harms from layoff are generally similar across race and ethnicity. So when layoffs occur, they are equally harmful along these dimensions. These are the results showing that that layoff increased the probability of income loss for all of our groups, increased the probability of severe income loss, defined as the loss of more than half of household income, increased what we consider housing insecurity, that is the inability to pay rent or mortgage, and increases the likelihood of a probable anxiety diagnosis or probable depression diagnosis. Next slide, please. Our second finding is that pandemic UI was very protective against the harms from layoff. So when folks experienced layoff, if they were able to receive unemployment insurance, it buffered against severe income loss, that's loss of more than half of household income, and it buffered against psychological distress. In addition, supplemental UI, so this is the additional payments of $600 a week that were available during the beginning of the pandemic, and then for a period later in the pandemic, the additional $300 a week that was available. Receiving those additional payments buffered against any income loss. So we saw folks were much less likely to experience household income loss if they received both UI and supplemental UI. And we found that supplemental UI made it easier to pay for housing and food. Again, we found that UI's protections, just like the effects of layoff were similarly harmful across race and ethnicity, the effects of UI receipt are similarly beneficial across race and ethnicity. Next slide, please. And here you see those differential effects of basic UI and then that additional UI. But you also see these very similar pattern of effects across race and ethnicity. Next slide, please. Finally, unfortunately, we found that Black and Hispanic workers and non-white workers overall were much less likely to receive UI with leakage at every point in the process. So, and the bolded numbers here, I should say, are when these numbers differ from the numbers for white respondents. So Black and Hispanic respondents were more likely to experience layoff. And then among them, if you could click, Hispanic respondents were less likely to feel able to apply for UI. Next slide, and next click. Both Black and Hispanic respondents were less likely to actually receive when they applied. Fewer Black respondents and Hispanic, although not statistically different, respondents actually received their UI early in the pandemic when the supplements were available. And finally, upon receipt of UI, fewer received a supplement. The net effect was that Black and Hispanic respondents were much, much less likely to receive all of the UI for which they were eligible than were white respondents, thereby missing some of the possible beneficial effects of this program to reduce racial and ethnic health disparities. Thank you.
All right, great. Thank you for that presentation. Terrific. Again, as a reminder, if the audience has any questions, please do make sure to put them into the Q&A box as we go along, and we'll make sure to get to them after the presentations are over. So let's move on to our next speaker, who is Caitlin Lowry. She's a doctoral student at the University of North Carolina at Chapel Hill, and she's going to be speaking today on changes in grocery purchases associated with the COVID relief produce incentive for SNAP participants in North Carolina.
Hi, and thank you so much. I am Caitlin Lowry. I'm a current doctoral candidate at the University of North Carolina, Chapel Hill. And I want to start by saying thank you to Health Affairs for organizing this session and to my co-authors from UNC Chapel Hill and Reinvestment Partners for their contributions to this work. So I'm going to be presenting today on changes in grocery purchases associated with a COVID relief fruit and vegetable incentive program in North Carolina called Healthy Helping. So Healthy Helping provided participants with $40 per month to spend on WIC eligible fruits and vegetables for a 3-month period. That generally means fresh, frozen, or canned fruits and vegetables without added salt, sugar, or fat. And in order to be eligible for Healthy Helping, participants had to be currently receiving SNAP or the USDA Supplemental Nutrition Assistance Program benefits, They needed to enroll via COVID relief hotline or participating health clinic or county social services agency, and they needed to self-report being impacted by the COVID-19 pandemic. And then these benefits were available between June and December of 2020, and they were funded through the North Carolina General Assembly's allotment of CARES Act COVID relief funding. And then these benefits were loaded onto the store loyalty card at the participating retailer and could be used at any of their stores, which included about 500 stores in 86 of North Carolina's 100 counties. So our objectives in this study were to understand if Healthy Helping enrollment was associated with an increase in the purchases of fruits, vegetables, legumes, and nuts. And then secondarily, to see if enrollment in this program was associated with changes in purchases of less healthy food groups, such as sugar sweetened beverages, salty snacks, and desserts and sweet snacks. So to answer this question, we used retailer scanner data from the participating grocery chain, which was linked to store loyalty card numbers so that we could identify which shopper IDs were making these purchases. And controls were selected from SNAP users who were not enrolled in Healthy Helping. And we used overlap weights, which is a propensity score-based method to help address confounding. So we assessed the change in monthly spending on fruits, vegetables, nuts, and legumes using linear mixed effects models with random intercepts for most frequently used store and shopper ID. And then we used a difference in differences approach to compare the change in purchases before and during the program among Healthy Helping participants with those of control shoppers over the same time period. And so as you can see in our control group, total spending on fruits, vegetables, nuts, and legumes at this chain declined, while in the Healthy Helping group, purchases of fruits, vegetables, nuts, and legumes increased significantly for a difference in difference estimate of $27 increase in fruits and vegetables and nuts and legumes spending. So then to answer the second part of our question, we also looked at the relative share of spending on different food categories. So these graphs just show the spending among Healthy Helping shoppers. And if you look at the green slice of the pie, you can see that before enrolling in Healthy Helping, shoppers spent about 13% of their food spending at this retailer on fruits, vegetables, nuts, and legumes. And then during Healthy Helping, that increased to more than 26%. And you can also see that among the less healthy food categories that we looked at, so salty snacks, sweet snacks and candy, and sugar sweetened beverages, we do see a decline in the relative proportion of funds going towards those products, although because overall spending at the chain increased among our Healthy Helping shoppers, there were actually small absolute increases in the amount of spending on these items. So some key takeaways are, our findings were that Healthy Helping successfully increased fruit and vegetable purchases by about $27 per month relative to our control group, which we think is encouraging given all of the challenges that were occurring early in the pandemic. We will note that this is less than the full $40 per month of the benefit. So we do need future research to understand factors associated with non-use or underutilization of the program benefits. We also need longer-term evaluations to see if the increases in fruit and vegetable, nuts and legume purchasing persists after the financial incentives decrease. And we think this has some positive implications for the WIC program's cash value benefit, which was increased for fruits and vegetables during the pandemic. Next slide, yes. Thank you so much for your time, and I look forward to your questions.
Wonderful, thank you for that presentation. Our next speaker is Benjamin Glassner. He is a postdoctoral research scientist at the Center on Poverty and Social Policy at Columbia University. and he'll be speaking today on the effect of the child tax credit expansion on the well-being and mental health of parents is unclear.
Thank you very much for that introduction. So as you can gather from the title, I'll be talking about the child tax credit. I want to thank my co-authors also at the center, and thank you to Health Affairs for having me here. So can we go to the next slide? So when we're thinking about the child tax credit, just to kind of review some of the changes that we saw, pre-expansion, eligible recipients would receive $2,000 per child per year in annual tax credits. These credits were not fully refundable, and they operated on a phase-in of 15 cents per dollar for earnings above $2,500. And because they were annual and not fully refundable, or primarily because they're not fully refundable, we know that this primarily missed low-income families. And then after the expansion, the maximum credit was increased to $3,600 for children under 6 and $3,000 for children between 6 and 17. The earnings requirement was removed. They were made fully refundable, and they were paid out monthly for 6 months and then given a large six-month lump sum. So we want to think about what effect this increase in payments had, and we're going to view the child tax credit expansion as if it's a cash transfer program in the traditional sense. Can we go to the next slide? So this structures our research question as, how did the child tax credit expansion affect the subjective well-being and mental health of parents and recipients? From the general literature on cash transfers, we know that quasi-experimental and experimental evidence has led us to believe that moderate to large cash transfers can improve subjective well-being and mental health. We want to see if that translated during the pandemic and the child tax credit expansion. And as a spoiler for the findings, also from the title, we don't find evidence that the child tax credit expansion had a significant effect on short-term measures of life satisfaction, anxiety, and depression symptomology among eligible adult recipients. A few things to keep in mind on the next slide is that experimental evidence of cash transfers often had very large or moderate to large payments, generally 25 to 100% relative to a previous annual income. The child tax credit is not going to show payments of that same size. In the US, we've used things like the earned income tax credit to do similar cash transfer experiments or estimates. And while we have seen that the EITC does improve subjective well-being and mental health in some scenarios or for some groups, we think that some of this has been mediated by increases in employment, not just the dollar amount of the EITC. So we want to think about how that improved long-term mediation impacts that measure of subjective well-being and mental health. And also permanent income or long-term changes in income are better predictors of life satisfaction than current income, i.e. a temporary income gain or shock doesn't necessarily improve life satisfaction. So on the next slide, we're going to use the Understanding America study, which is a nationally representative panel survey conducted by the University of Southern California to study this. We're going to focus specifically on families with children. We're going to use 3 measures in our study, one being life satisfaction, one being the GAD-7, a measure of anxiety, and the CESD-8 for depressive symptoms. We're also going to use a treatment that's going to look at the net change in child tax credit benefits. So how much more money were you receiving via the CTC as a result of the expansion? This is going to be based off of the reported household income, the number of children and age of children that we have in the data. And we're going to use a two-way fixed effect difference and difference approach for our primary findings, but we also include robustness checks using the Tallaway and Santana estimator, given the recent literature on two-way fixed effects. Next slide, please. So to dive into the results of what we're finding, we're going to look across our 3 measures: life satisfaction, the GAD-7 for anxiety, and the CESD-8 for depressive symptomology. And can you go ahead and do the first click? So for our life satisfaction measure, we find that for an additional $100 in net CTC payments, so more CTC than you previously would have gotten before the expansion, we find that the results are statistically insignificant and that they were reduced by a very small value of 0.05. For our measure of anxiety, $100 for net CTC payments increased our measure of anxiety by 0.05, was statistically insignificant. And for depressive symptomology, we're going to find that it reduced that by 0.12, also statistically insignificant. So across the board in our models using the two-way fixed effect, we see that our estimates of the effect of the child tax credit expansion is null. Now, there's a few things that we want to think about for why this might be, and we're going to discuss that on the next slide. So we find null across our three measures of life satisfaction and mental health. The effects are small and insignificant. And when we think about where that fits in with the previous literature, well, most of that was done in low and middle income countries with relatively large transfers relative to previous annual income. The child tax credit expansion, while large and significant in many ways, as the literature has shown, might not really get to that same level of an impact. We also know that the literature has been focused on permanent income, which is a bigger factor than temporary increases or small shocks. And so the fact that many people viewed the child tax credit expansion both in name and in principle likely to be only temporary might have undercut some of the benefits that the policy had. There was some thoughts that maybe it was just exactly offsetting the negative effects of the pandemic, and that's why we didn't find significant effects. But we find no evidence of trends across payment size, family composition, household income, or sex. So when we think about the general effect of the child tax credit expansion, we see that it's null, and that maybe we would have found positive effects if the CT expansion was made permanent or extended over a longer period of time. Thank you.
All right, great. Thank you for that presentation. We have one more presentation left to go. So just a reminder to everyone to please put your questions in the Q&A box. The Q&A is coming up next. Last but not least then, we have Dr. Alina Schnacki-Mall, an assistant professor at the Dornsife School of Public Health at Drexel University. And she'll be speaking on paid sick leave and COVID-19 vaccination coverage, a longitudinal analysis of 37 large US cities in 2021.
All right. Thank you very much, Dr. Hamad, and thank you for the opportunity to present today. I'm presenting on behalf of my co-authors. And this work looks at paid sick leave policies across large US cities and associations with COVID-19 vaccination and vaccination disparities. So the United States is one of few wealthy nations without a national paid sick leave policy. Instead, we have a patchwork of city, of state, and employer policies, but the patchwork has holes. It leaves nearly a fourth of US workers without access to paid sick leave. So I'll note that a number of states and cities enacted paid sick leave policies before and in the first year of the pandemic. And there was a federal paid sick leave policy in 2020, but it ended before vaccines became widely available and instead was replaced with a voluntary program with tax credits. So paid sick leave may be important for vaccination for a number of reasons. First, it provides paid time off to get vaccinated. And secondly, it provides paid time off to recover from side effects. However, there are wide disparities in who has access to paid sick leave. In particular, low-wage workers and workers of color are less likely to have access to paid sick leave compared to white workers and higher income workers. And these same populations have died and been hospitalized and infected from COVID-19 and had lower rates, and have lower rates of vaccination. So in this way, the lack of paid sick leave policies and the inability to take paid time off to get vaccinated may create a structural barrier to COVID-19 vaccination. So in this analysis, we wanted to look at the question of whether or not paid sick leave policies were associated with COVID-19 vaccination and COVID-19 vaccine disparities in 37 of the largest cities in the US in 2021. So we compared cities with paid sick leave policies to those without paid sick leave policies. And we controlled for the factors that may confound the relationship. Or using non-epidemiology language, we accounted for alternative explanations for differences in vaccine rates, other than paid sick leave. So we're controlling for these differences in who lives in these places and also the differences in the places. So as an example, we're controlling for how people voted in the 2020 presidential election. So in the interest of time, I'm not going to dig in too much on the methods details. I'll point you to our paper for further details, and I'm happy to answer more methods questions in the Q&A. But I will note that we include a number of sensitivity analyses to consider alternative explanations for our findings, and we find that our results really are consistent across analyses. Next slide, please. Thank you. So ultimately, we find that there was a statistically significant 17% higher vaccination rate in cities with paid sick leave versus those without, among the working age population. And this is after adjusting for those differences in places. We also include this idea of a negative control. And in that negative control, as expected, we don't find a relationship for the population age 65 plus. So they're largely retired. And so we wouldn't expect them to benefit from paid sick leave policies. And you can see that in the figure in the yellow line, and it's also available in our regressions in the paper. Next slide, please. So we didn't just want to examine COVID vaccination levels. We also wanted to understand disparities in vaccinations. So here we look at the 16 cities that have data available at the neighborhood level. And we connect that data to the Social Vulnerability Index, which is a measure developed by the Centers for Disease Control to assess a neighborhood's ability or a community's ability to withstand disaster, such as an outbreak of an infectious disease like COVID-19. And we have two major findings from the disparities analysis. First, we find narrower COVID disparities between the most and the least vulnerable neighborhoods in cities that have paid sick leave policies. So in the figure, the cities with blue are cities with paid sick leave policies. And you can see that there's a narrower difference between the neighborhoods in the blue than the places in yellow. Specifically, we found that there was a 29% gap between the most and the least vulnerable neighborhoods in cities with paid sick leave versus a 72% gap between those neighborhoods in cities without paid sick leave. And then secondly, we find that the strongest impact of paid sick leave policies are in the most vulnerable neighborhoods. So this additional benefit of paid sick leave policies for the most vulnerable neighborhoods is likely because higher income people and people living in less vulnerable neighborhoods are more likely to already have access to paid sick leave from employers or are able to work from home. So these benefits of having a paid sick leave policy, mandated policy, may be concentrated on among the populations without existing paid sick leave policies, say from employers. Next slide, please. So all of these findings add to existing research that demonstrate how access to paid sick leave benefits various health outcomes, including COVID infection, flu hospitalizations, and flu vaccinations. But our research specifically suggests that paid sick leave policies may help increase COVID-19 vaccination and reduce inequities in vaccine coverage. So removing that barriers to vaccination, this may be increasingly important, as in the United States, we've removed nearly all of the COVID-19 restrictions. So we're now really solely relying on vaccination and boosting to try and keep COVID-19 deaths and hospitalizations down. And our research really suggests that paid sick leave is a key policy to help people get vaccinated, particularly in the most socially vulnerable neighborhoods. But there's a challenge, and that's that we have a patchwork of paid sick leave policies, leaving many places in the US without access to paid sick leave. So there's an opportunity for the federal government to enact a paid sick leave floor while allowing cities and states to perhaps enact more generous benefits. But that's politically probably quite unlikely at this stage. But there is an opportunity for cities and states, particularly without paid sick leave, to enact these policies. And further, there's a number of states that have preempted or prohibited cities and counties from enacting their own policies. So there's an opportunity here for these places that haven't even enacted their own policies to, at the very least, remove the preemptions and allow cities and counties to put in place their own policies. And last, there's opportunities for employers to provide benefits to employees, especially in places that don't have paid sick leave policies. And then last year, I'd be remiss to not mention, because it's election day today, that all of these policies are dependent on who we vote into power. So voting for candidates that support paid sick leave is key to expanding access to paid sick leave, to increasing COVID-19 vaccination coverage, and reducing vaccine disparities. So I want to just wrap up by reinforcing the findings of our article, which is suggest that paid sick leave is important not just for increasing COVID-19 vaccination rates, but for reducing inequities in COVID-19 vaccination in the populations worst impacted by COVID. And therefore, expanding access to paid sick leave may be an important step to advancing health equity. So with that, last slide, please. I'd like to say thank you very much to the co-authors of this work, as well as our funders. Thanks.
All right, great, thank you. Yes, it is election day, so everybody, after you attend this presentation, please do make sure to get out there and vote if you haven't already. So those are all of our presentations. We have about 15 minutes left for questions. If you haven't already, please do put your questions in the Q&A box. Feel free to do that now. Our first question is for Dr. Ananat. You mentioned that racial, ethnic differences in take-up of unemployment insurance were not explained by differences in education, industry, or work attachment. Can you postulate a bit about what those barriers to access might be? For example, whether they're related to aspects of structural racism or discrimination based on immigration status or something else?
Sure. So first, I'd like to clarify there are disparities in UI receipt based on the factors that you mentioned, but within our sample, those disparities don't exist. Our population across race has similar characteristics in terms of eligibility for UI, in terms of education, et cetera. So we have a highly similar group of people who experience the similar event of layoff from the similar type of job, and yet it's still the case that they experience disparities in access to UI. And the previous work had all documented differences in UI receipt that was based on these factors that you identify. So we aren't able fully to identify what the causes are. We do see, however, Hispanics, one of the big drivers of their lower UI receipt is that they're less likely to apply. And we know that some of that is because of differences in treatment by documentation status, which is, particularly problematic in the case of UI, because of course all workers are paying into the unemployment insurance system through their paychecks, and then some folks, because of the statute, are not eligible. In addition, lots of folks we know who are eligible, they have documentation, aren't accessing UI because they are afraid about the implications of using a government program for undocumented family members, right? Particularly at the time that the pandemic started, there had just been a move to push this public charge rule, right, by the Trump administration that would penalize folks when they attempted to get citizenship if they had used an unemployment, any sort of government program in the past. These lead to chilling effects, right, where entire communities become trepidatious basically about attempting to access government programs that they are eligible for. So that's one thing that we think is going on. Another thing that's going on, we speculate, there's work by Alex Goldworth of the Washington Center on Equitable Growth showing that workers of color, their employers are more likely to challenge their claim that they are eligible for UI and to refuse to cooperate in the documentation of their employment that is necessary. We also have evidence from other programs, not from UI, although we're working currently with Caroline Barnes, who's a professor of political science at Duke University, on documenting this for the case of UI. But for other government programs, there is evidence of racial disparities in the way folks are treated by caseworkers and assisted by the program. So we suspect that the fact that folks are less likely to make it through the application process and less likely to be approved when they apply by race may be due to bureaucratic structural racism. And then a third thing is folks even who applied were less likely to actually receive. And that may be due to differences in mail service, mail security that we know affect communities of color, where it may be that you actually should have gotten this, but it didn't actually arrive. Of course, you can get direct deposit, but we also know that there are huge differences by race because of structural racism in access to bank accounts. Thanks.
Great, thank you. Another question also sort of relates to administrative burdens. This is for Benjamin Glassner. So as you mentioned, we know from other work that the earned income tax credit and other income support programs result in improvements in mental health. So if other studies replicate your null findings, are there any concerns that take up of the child tax credit was suboptimal, particularly among those who don't typically file taxes? And if so, what might those policy implications be?
Yeah, I think, looks like I can't turn my video on. All right. There we go.
Yeah, we can see you now.
Perfect. So I think that's a great point, that take up, at least in the initial wave of the child tax credit expansion, really relied on you having filed taxes previously and having some, particularly if there was direct deposit information that the IRS already had, then that money would have gone to you directly. And those most likely not to have filed taxes or have that information available would have been the most vulnerable individuals, as well as low-income individuals most likely receiving the largest increase or relative increase in the child tax credit. So it's a great question on maybe that's one explanation for the null result, but we did end up also including information as a robustness check on reported receipt of the CTC and still found null results. on the effect of it from the actual implication of if it truly is just we're not finding results because of administrative burden or access to those policies. If that is actually what we end up finding with more investigation, the child tax credit, I think it's a great case for the universality of the child tax credit expansion by making it easier for people to get access to these things. If we are finding positive effects of it, that's all the more reason to make it easily available for individuals. So it's a great question, something that we really want to try and dive into. It's a little bit difficult to estimate in the actual universality of it because finding good control groups when everyone's getting it is hard, but I think it's a good point. We tested it to the best that we can, but I think it's something we'll kind of get more information on as the policy expands out.
Great, thank you. Another question about our first presentation from Abdel Nasser Ali. So were there any differences or were you able to measure any differences in your effects between private home renters and people who are renting from large apartment complexes?
I also can't open my video for some reason. There you go. I think it's good now. No, our study primarily focused on just renters and homeowners. So there was no differences in terms of what we were looking at, whether there were large renters or small private rooms. So the focus was, and this was, and we were primarily guided by the survey question, which asked, do you rent your home or do you own your home? So that was what we were guided by, and so we only looked at renters versus homeowners.
Okay, thank you for clarifying. Another question, this one is for Dr. Shnaki Mal, our last presenter. So you described the importance of paid leave for COVID-19 vaccination and reduced transmission. I wonder if you can speak to the lessons about paid leave that might extend beyond the pandemic, for example, to other infectious diseases or even regarding the use of paid leave for other preventive services like colonoscopy.
Thank you. Yeah, I think that that certainly other research, and our work really is building on existing research. Other research has looked at a number of different outcomes. So I mentioned briefly that there's been work published in Health Affairs around COVID infections, work published elsewhere on influenza hospitalizations, on influenza vaccination, on preventive care, on not going to work when sick. So there's been a lot of research that's out there that really suggests that this is an important policy across a number of health areas. And I do think some of the importance of that is not thinking about just temporary COVID policies, right? Because there are kind of these numerous outcomes and potential impacts, it's important to think about it as sort of a permanent policy, not just temporary. Ours, I think one thing that it particularly does is look at that disparities angle that I haven't seen in a lot of previous research. And I hope that going forward, it's something we'll do more on. I would also say that much of the work, and ours in particular, or including ours, only looks at, is there a paid sick leave policy or not? And some of the features that may be really important overall for impacts and for disparities are the features of policies. So for example, in Berkeley, California, where I'm from, they include that you have to post about paid sick leave policy availability at any employer place in the language of the majority of workers. So things like that around dissemination and communication may be super important for impacts overall. So I think it's a space for more research, but we also have a lot of evidence to suggest it has benefits.
Great, thank you. It sounds like we're hearing a lot of themes around the issue of administrative burdens and take up of these policies. Another question, this is for Emily Dorr. So which states did you include in your study, and are you able to speak to the differences across states in terms of the policies that were passed?
Yes, so we included all states in our analysis. It just varied in terms of whether the states implemented the particular policies that we looked at. So we have two maps in our paper that shows which states enacted two of the policies that we looked at. And then our supplemental materials have the rest of the maps for each of the policies. So I'm not sure it's really worth it for me to name the exact states, but if you are interested in looking, you can, all that information is available. I'll say that the number of states really varied from, there were 2 states that implemented the subsidized wages for cut work hours. So that was the policy we looked at with the fewest number of states that implemented a policy. And the policy with the most number of states was waiving work requirements, which was 37 states. So I hope that answers the question.
Great, thank you. Let's see, we have a question for Caitlin Lowry. Typically, SNAP doesn't have restrictions on food categories in the same way, for example, as WIC benefits, where it's very specific what you're allowed to buy. So might the restriction in the food vouchers that you were examining, might this have affected the spending? You know, I think you guys saw that you didn't get the full $40 spent. So something about like the flexibility of the benefits, or people's cultural preferences couldn't be met, or something along those lines.
Yeah, sure. Yeah, that's a great point. And right, SNAP can be spent on, you know, virtually anything except that is food and not prepared or hot food. Whereas programs like WIC have much more specific sort of requirements for what it can and cannot be used for. So that's definitely a possibility. This is, you know, in addition to their regular SNAP benefits that they were receiving. So this is kind of an add-on, not in place of. It's possible that there was some, you know, confusion about what was eligible, or that people weren't necessarily interested in the items that were available. Although, you know, given that it's at a supermarket, whereas many of these programs have been implemented in farmers markets and things that have, you know, are more limited to just fresh produce, we think that hopefully that wasn't a huge limitation. As I mentioned, the benefits could be used for frozen, fresh, or canned products, as long as they didn't have the added syrups or a lot of added sodium and that type of thing. But that certainly could affect uptake.
Great, thank you. Another audience, this one is back to Dr. Shanaki Mal. Were you able to assess differences in vaccine hesitancy across the city you studied, and could that have been a contributing factor?
Yeah, so we don't directly look at vaccine hesitancy, but we look at some kind of upstream determinants of vaccine hesitancy. So we know that there are differential vaccine hesitancy patterns, both by socio-demographic group and by political lean. And so we both control for political lean and for those kind of socio-demographic differences. We also include this measure called the COVID-19 Vaccine Coverage Index that has measures around these kind of socio-demographic, compositional differences, some contextual differences that may influence vaccine hesitancy. So we include those, and I'll say that we have in the appendix, you'll see that there are some DAGs for all of my epidemiologists. We got a DAG in health affairs. And so you'll see that we have kind of different causal assumptions about what we're controlling for in those that are available there. But we are controlling, essentially we are controlling, no, not directly for vaccine hesitancy, but we are really probably capturing that, but it's always possible that there's some residual confounding.
Great, thank you. And I think this is probably going to be our last question because we just have a couple of minutes left. But this is back to Abdel Nasser Ali, our first presenter. So in subgroup analyses, you guys noted that effects were strongest for Black and white renters, with sort of much smaller coefficients and non-significant effects among Hispanic and other racial ethnic groups. Similar to the unemployment insurance question we had earlier, is there anything about the eligibility requirements or other administrative aspects of these moratoria that would lead us to think that immigrants or non-English speakers may have been ineligible or somehow otherwise not able to benefit?
That's a great question. How much time do we have?
Two minutes left. See what you can do in 2 minutes.
So because we were analyzing these moratoriums at the state level, there was so much different in, the justifications that were used were different. How they were put together, which actor did it, whether it's the state legislature or the courts that put out the moratoriums, or the executive arm of the state governments through the governor's office. And so, the policy variations in, the implementation was so varied and so much different, and that, that's a factor that we had to consider. But for our analysis, what we did was that we linked the survey dates for the survey participants to whether that particular state had an eviction moratorium or not. So that's what we did. But these moratoriums were so much different, you know, the scope, even the timing of it, right? So the eviction is a public process, and so there are 5 stages in eviction. So the first stage, if a tenant doesn't pay rent after the 5th of the month, there's a notice that is put on the door, and then a few days later, an eviction is. So that's the first stage. An eviction is held through the court process, and then there's a judgment, and then enforcement later on by a sheriff or local police, right? So those 5 stages. So there were moratoriums that targeted the initial 2 stages. Sort of stopped the landlords from issuing, notices, and then there were other states that targeted just the last stage or stop, close court so that evictions doesn't happen or hearings are not held. And then finally, there were other states that implemented, their moratoriums through the very last stage, enforcement, prevented police from actually or sheriff carrying out an eviction order. So that wide variation at the state level, I think, could also be a factor in that. What we're trying to do, the next step here is to evaluate now at the national level. So there were 2 federal moratoriums through the CARES Act in March of 2020, and then later on through the CDC. Perhaps that would give us more insight into that and look at the interaction between the federal and state moratoriums. I hope that answered the question, but I think this is a challenge with trying to analyze policy at the local level with so much variation in at both the state and the local level.
Great, thank you. All right, so that's all the time we have for questions. Thanks again to our amazing presenters and to the audience. I'd encourage everyone to check out today's issue of Health Affairs to read the full articles and the other ones whose authors weren't available for presentations today. And I'm now going to pass it back to Alan for our policy panel. So we're not done yet. Stick around.
Thank you, Rita, and to our authors for those great papers. We now want to put the work, the scholarship, into a policy context. We have 3 excellent panelists who are going to discuss some of the themes that reach across the papers in addition to the specific findings that you've heard today. We're going to have as a panel, Erin Arango Escalante, Administrator at the Division of Early Care and Education at the Wisconsin Department of Children and Families, Aditi Malik, Chief Medical Officer of Medicaid and CHIP at the Centers for Medicare and Medicaid Services, and Brian Smedley, Equity Scholar at the Urban Institute. We're going to bring these into our conversation. So we've asked them not so much to speak specifically to the findings in the papers, but to bring really a policy lens to the topics that were discussed today. I've asked each of them to spend just a few minutes giving a little bit of context to the perspective they bring to the conversation, some observations they have about what they've heard, and to just sort of introduce their approach to these issues. And then we have about half an hour that we'll be able to have a deeper conversation and bring audience questions in as well. So Erin Arango Escalante, you look at this from a state administrator perspective. We heard already in the Q&A among the authors a lot of reference to implementation. So maybe I'll turn to you first to just welcome, to introduce yourself and give some opening thoughts.
All right, hello everybody, and thank you for the opportunity to be here. My background is in early care and education, as well as special education, multilingual learners, educational leadership, and policy analysis. And so many things that the authors spoke about today really resonated. Currently, I am the administrator, as you mentioned, of the Division of Early Care and Education at the Wisconsin Department of Children and Families. And the division that I oversee leads childcare, every aspect of childcare and policies related to childcare, as well as Head Start. We also were recently awarded our preschool development grant, the first year of 2020. And as part of our big, bold vision, we're very much in support of connecting the dots across policies that support children birth to 5 and their families and communities. And so as part of this grant, we were really pushing the needle and connecting the dots for children and families, looking at policies that were discussed here as well as others, looking at program level as well as implementation, and how to do what's best for children and families. I'll just mention one quick thing and then I'll let others introduce themselves, but at the core, I believe, of what we are doing with policy in Wisconsin is really lifting the voices of those with lived experience as we're creating policy, making programmatic decisions, funding decisions, all of those decisions that impact the families that you all talked about today, raising the voice and really building a much bigger, more diverse table that is inclusive of those with lived experience has been critical. And that is something when we're thinking about the policy that we are pushing towards, so that when we're creating or implementing various policies in our state, they make sense for the people who live in our communities in Wisconsin. So I'll stop there, but I'll have more to share later. Thank you, Alan.
Thank you so much for those opening thoughts. We've heard the view from a state. Why don't we bring in a view from the federal government? Aditi Malik, you're at CMS. Please go ahead and introduce yourself and some opening thoughts as well for the audience.
Thank you, Ellen. And I will echo the thanks to all of you for joining in, for the opportunity to join the conversation. Aditi Malik, I'm the Chief Medical Officer of Medicaid and CHIP at CMS. I lead our work in our policy development and health equity and the social determinants of health, and how we can use policy to help address health-related social needs. Most recently, folks might be aware of a few Medicaid waivers or 1115 demonstrations that were approved in Massachusetts, Oregon, Arizona, and Arkansas, related to addressing health-related social needs that are a major driver of health disparities. In particular, relevant to today's conversation around things like housing stability, nutrition security. In a not so distant former life, prior to taking on this role, I helped lead COVID-19 response efforts for the North Carolina Department of Health and Human Services. And that included launching large-scale vaccination sites across the state when vaccines became not so widely available at first, if folks remember, and then more widely available as time went on. So have seen the impacts of the pandemic, both from a state level and the federal level, and now really spend the bulk of my time focused on how can we use policy, which is albeit a very blunt tool, to help shape the environment in which governments at all levels, in conjunction with the private sector and other interested parties, can really address economic or social issues, or what are traditionally thought of as economic and social issues that really do impact people's health. I will +1 everything that Erin said, and my opening bid to you all is this policy is really just the first step. That implementation is really where the proverbial the devil's in the details. But things like the ability to track data, the ability to have partnerships across all levels of government, and to break down the silos that often exist across social services programs and across local, state, and federal programs. And that really involves kind of rolling up your sleeves, getting your elbows dirty, and into some what I'll call unsexy things, right? Like data use agreements and cooperative agreements and regular convenings, but that are really, really important to actually make sure that this work translates. Much, much more to be said, but I will turn it back to you, Ellen. Looking forward to the discussion.
Great, thank you so much. And now I'd like to bring in Brian Smedley from the Urban Institute. Brian, introduce yourself and a few thoughts as well.
Sure. Thanks so much, Alan. And my thanks to the presenters for really outstanding and excellent papers. Brian Smedley, Equity Scholar at the Urban Institute. My focus, my interest is on the role of racism in shaping public policy, as well as shaping the political and societal determinants of health. So I found these papers to be enormously interesting and fascinating from that viewpoint. The first lesson from these papers is obvious. Economic policy is health policy with enormous implications for equity. I sure appreciated the sensitivity of the authors to the fact that not only are these economic policies potentially mitigating against some of the risks during COVID, but also particularly helping those populations that have been marginalized as a result of racism and other forms of inequality. The other thing that should be noted, and I'm sure all of the authors and respondents will agree, is that these particular economic policies have broad impacts, not limited to the specific outcomes, the specific dependent variables that were examined here. For example, the child tax credit was enormously successful from a public health standpoint for the very fact that it reduced child poverty enormously. We don't want any children growing up in poverty. It damages their health and well-being over the course of the life cycle. So to the extent that we can support families with sound economic policies, this is enormously beneficial, and particularly beneficial for those populations of color that are disproportionately in lower income tiers. What I would love to explore further is the important role of state and local variation. This was a wonderful natural experiment to begin to understand how policies and the variation in how policies are carried out varied across states. And I think a number of authors have pointed out, it's not just the policy broadly, but how you implement it that makes a difference, and particularly from an equity standpoint. Final thing I'll say, and I hope we can dig into this more, racism complicated the United States' response to COVID. And I think in part, the reason why the United States fared so poorly during COVID is because of racism. I sure appreciated the article by Steve Wolf in this special issue where he points to very specific factors such as our dysfunctional healthcare system, poor adoption of public health behaviors such as mask wearing, environmental health threats, including racism, socioeconomic adversity, and policies that don't help our populations to be healthy. What I want to suggest is that racism is a thread that weaves through all of those factors. There's a growing body of social science research showing that the more among some sections of the electorate, the more policies are perceived to be helping populations of color, the less political support there is for those policies. I think we see that borne out in terms of the distribution of which states and localities have adopted policies that were beneficial for the health of populations. These are largely progressive states. Looking, for example, just at the example of sick leave, the 12 states that have adopted statewide sick leave policies are limited to the Northeast, as well as progressive states in the West, with the possible exception of Arizona. So we need to consider the role of racism in diminishing support for policies that are beneficial broadly, but particularly for marginalized populations, and particularly during a syndemic such as COVID, where pre-existing inequities were made worse by the viral spread. I'll stop there.
Well, thank you to all three of you for just getting our thoughts flowing here. I want to use, Brian, your comments as a point of departure to go a little deeper. Certainly from a researcher's perspective, the variation at the state and local level is this great opportunity for a national experiment. We can learn from it. But the degree to which our safety net is this combination of national, state, and local programs is very complicated for a lot of other reasons, including the ability of families to negotiate it, the ability to build a coherent response to an emergency like COVID. So as someone who's worked a lot in state government myself and has always been interested in federalism, maybe it's not surprising that I take this as our first topic, but I'd love to get a conversation going amongst the three of you about two dimensions, and I'll sort of let you pick which one you'd like to lead with. One is the relative pros and cons of the variety of federal structures we have for the kind of safe economic supports that we've discussed here. I'm not talking health policy, we have that too. But also then the ingredients for successful intergovernmental cooperation, that setting aside whether we've designed it the right way or the wrong way or the pros and the cons, what does it take to achieve positive outcomes in a system that for the foreseeable future will rely upon federal, state, and local initiatives? So sort of both a normative and a more descriptive question, but who'd like to get us started in this conversation?
Alan, I don't mind jumping in there. Your observation is exactly right. We have, importantly, a balance between federal, state, and local approaches. And I agree with those who argue that state and local governments, in many cases, are better prepared to understand the needs of their communities. I sure appreciated the comment of one of the authors that we need to listen to communities and understand lived experience to shape policy. That old saying, nothing about us without us, is so critically important. And so that's critical. But we've seen the failures of state and local leadership, particularly around Medicaid expansion. So the failure of some states to expand Medicaid clearly was almost a pre-existing condition for COVID to make it worse. And so this is part of the fracturing of our healthcare systems that Steve Wolf and others have pointed to. So it is a difficult balance, but clearly there must be ways that the federal government can offer a floor of support where state and local governments can build upon that floor with the understanding of the particular needs of communities that are most marginalized and most needy.
Yeah, I'll add. So on the first question of kind of relative pros and cons of the variety that we see across state and local jurisdictions, I completely agree with Brian. I think the single biggest pro, I would put like the plus in that column, is the ability to tailor to local needs, right? Urban, rural, people that speak a certain language, or people of may gravitate to a certain faith. They may have certain leaders in the community who they trust and want to be the voice or champion of things, or there are policies. You know, a fishing town is going to have different needs from a mining town, is going to have different needs from a densely populated urban center. And so that ability to tailor, whether it's unemployment, eligibility criteria for social services, childcare needs, is, I think, incredibly important. I think the single biggest con, completely agree with Brian, like the lack of consistency means where you live and your zip code determines your life expectancy and determines your health outcome, right? And a large part of that is racism, as Brian has said, but a large part of that is the politicization and the a la carte pick and choose of economic and social policies that we know, and as many of the authors have shown, does have downstream health impacts. And that just, you know, fundamentally, one could argue, feels a little bit unfair, right? That where you live and the milieu of economic and social policy of that place drives your health outcomes to a smaller or lesser degree, depending on what the policy is. To the second question of ingredients for successful intergovernmental collaboration, again, I say this having been on the state side early in the response and now working for the federal government. I think open communication and transparency around what you know, what you don't know, what you're thinking, and really a willingness to come to the table and problem solve together is incredibly important. You know, I'll use an example from my state experience, but you know, there was a time when we didn't know how many vaccines we were getting. We didn't know when they were coming. We didn't know, similarly, we didn't know when we were getting antigen tests, how many antigen tests we were getting, when would they expire, how could we use them, you know, and that lack of transparency really hamstrung, I think, a lot of efforts that could have been much better coordinated. Similarly, along the messaging, right? The messaging along for masking, the messaging for how each pocket of from one county to the next or one municipality to the next would have different rules for indoor masking, would have different rules for whether schools would be open or curfews and things like that. And when you bring people together for intergovernmental collaboration, it allows for some amount of compromise that creates consistency and an openness that I think really fosters trust too. And I'd say, so I think the other key ingredient for successful intergovernmental collaboration is to be truth-based and fact-based and trust-based. I think the pandemic, among the many, many lessons of the pandemic, was how the politicization of facts and the politicization of science can really cut off at the knees a meaningful public health response. And so a willingness to engage in facts and healthy disagreement and healthy discourse, right? I don't think anyone knew what the right answer was for schools. I don't think anyone knew what the right answer was for masking, at least for a period of time, right? But a willingness to engage in those questions in a way that is productive and fruitful, as opposed to name calling and creating factions, if you will, that are unwilling to talk to each other, I think is the single biggest thing that I think hamstrung this response, and I think is a lesson learned for moving forward.
Erin, do you want to jump in?
Yeah, I'll just add a few thoughts. I absolutely agree with both panelists. I think they're spot on. One of the things that I'm working on as an Ascend Fellow with the Aspen Institute is thinking about a theory of action related to marginalized communities in Wisconsin, and thinking about, if we look at those communities that have the poorest health outcomes, highest incarceration rates, the highest infant mortality rates, look at all of these different indices, and we say these particular communities have been the furthest away from doing business with the state. And we identify by looking at data, et cetera. We look at very diverse communities, an urban, a rural, a tribal, small, medium, large, you name it, all these different ways, and kind of slice and dice the data. If we can figure out how to bring and lift the voices of those within those communities, bring them together and think about the systems, the policies that work for these individuals based on their experiences, I think we can then begin to crack the nut, and that becomes the floor that you talked about, Brian, right? That floor that what we're hoping that the feds will do for us. But that may have to happen at the state level, and that's something that we've just started in identifying, again, parents, caregivers, those who are benefiting from the policies that we've all talked about today. So there is, I think the pros and cons that were talked about were spot on in terms of customizing, tailoring to meet the needs of those in particular communities is key. But that lack of consistency, which then also has a ripple effect into the lack of consistent data, the lack of shared resources, the lack of, of funding, et cetera, it sort of ripples as a con. So I think there's a lot to think about there, particularly when you're a state that has local control. There gets to be a lot of differences, and it gets a little bit tricky. I do think that with regards to intergovernmental collaboration, I think there's a lot of sort of ingredients that were mentioned. Trust, communication, breaking down those silos is really, really key. But I think very importantly is at that leadership level, having leadership buy-in, that there is a need to connect the dots across all of these various areas so that you can move particular policies forward. And I'll give just a little bit of an example here. During the pandemic, there were a lot of issues coming up: masking, immunizations, all of these things. But one issue that rose that we didn't think was going to rise, and I think this is the silver lining of the pandemic, is the importance of early care and education in childcare. This just popped up, and it popped up quickly, particularly from businesses, employers, and others. And it became a very an issue that both sides of the aisle said, pay attention, this is important. And we had a situation where every agency, so whether you're Department of Natural Resources, Department of Transportation, Department of Corrections, it doesn't matter. All agencies became acutely aware of the issue and paid attention and supported childcare from their vantage point, which is tricky to say, hey, Department of Corrections, focus on this right now when you're in the middle of a pandemic. And everybody did. And I think that was I think an example of there being a crisis, and there's all hands on deck to support a particular issue that would never have received this attention had the pandemic not happened. And I think it's an important just flip side of the coin to just mention that, yes, the pandemic, it's awful. It was a horrible situation. And if there is a silver lining, it's this. And so based on what's happening with all of these other agencies, we've discovered, obviously, workforce, economy, people are struggling to go back to work. We're struggling with our economy, and truly the workforce behind the workforce is childcare. And now we're seeing so much an influx of philanthropic dollars, of business and employer-sponsored childcare, we're using our American Rescue Plan Act dollars in different ways, but we're making decisions differently because we've listened to those that are living and breathing in our systems, and we all come together to say, this is a priority right now, let's do something about it.
I appreciate you all tackling both halves of my question. I guess I want to push back just a little bit on one thing that came up, which is the value of local control. I certainly understand if you're creating a job training program, you need to know the local economy. I can even understand in some of the non-medical interventions for COVID, you need to understand the local culture. But I'm curious, for the policies that were the focus of these papers, paid sick leave, unemployment benefits, are these really local? And by that, I don't necessarily mean local, I could mean state. Do we really benefit that much from saying these should just be up to the political desires of the state or locality? And I guess I ask it in part in the context of Rachel Wick's opening comments, which is part of why it's important to study events like these, is to learn from them. And if, again, you never want to draw too many strong conclusions from a handful of excellent peer-reviewed papers published in Health Affairs, but the evidence seems pretty overwhelming that these are positive for health. And if we take that learning and then sort of say, do with it what you will, are we really getting all of it, all that we should out of this? So do we need local control over these kinds of economic support policies?
You know, Alan, I think the devil's in the details. And so for me, local control is about understanding specifically how variations in program implementation can be tailored to the needs of a particular community. But I think, to your point, federal leadership is so critically needed. If we know these economic policies help us emerge healthier from a global pandemic, seems like the federal government would have a role in providing that leadership in terms of broadly providing resources and support. But then I think these papers also suggest further that the actual implementation and with particular attention to the needs of marginalized populations can be an area where local authorities have a significant and important role.
Other reactions to this?
I agree. I agree with Brian. I think the devil's in the details. I really do. There may be a standard policy, but implementation, communication, outreach, all of these other factors, thinking about accessibility of this information in multiple languages, at specific reading levels, all of these things are really important. And oftentimes we think there's a one-size-fits-all approach. It doesn't work. And I think when you see like uptake rates of certain benefits or this, that, and the other, it's when you kind of peel back that onion, the unfortunate implementation has caused there to be issues with what you thought you were implementing and hoped to implement that didn't go the way you intended.
And I will be the caboose here and maybe play devil's advocate to say resources are not infinite, right? And so states in particular, and I'll put the federal piece aside because I think there's a compelling argument to be made that these investments in good and sound economic and social policy pay off in dividends in terms of people's health over a longer time horizon. By the way, I think, and this came up in some of the papers, that 6 months or even 18 months is not necessarily a long enough time horizon to see what I certainly have a very strong hypothesis, I think has actually been borne out in other literature, that were we to look over a longer time horizon, actually really meaningfully impact people's health. Put that aside for a second. States have to balance their budgets. States saw their tax base and their tax revenue base take a massive hit during the pandemic, right? And yes, there was a tremendous infusion of FFCRA and relief dollars, just coronavirus relief dollars across a number of pieces of legislation poured into state budgets to help stop gaps and keep critical programs afloat. But that said, there's not an infinite amount of money to fund everything that we know is good. And so the one argument in favor of the local ability to the value of local policies is that the local electorate can say, okay, of this a la carte menu of things that we think are good, what rises to the top of the pile in terms of prioritization? Yes, in an ideal world, we would loosen the administrative burden on TANF, we would implement paid sick leave, we'd offer widespread unemployment benefits, et cetera, we'd delay eviction, we'd have eviction moratoriums ad infinitum, but all of those things cost money. And so I think locally it allows for, again, some prioritization or some tailoring to say, okay, if we can't have the whole pie, what are the pieces that we think are most important?
Well, I appreciate all of those perspectives. And I asked the question not because I think there's a right answer, but because I think we need to have these conversations. Let's continue a little bit on this theme that just came up, and it's come up throughout actually the author presentations as well as your opening remarks, which is the role of reaching into the communities and engaging those who are most affected by these programs. So I think it would be fair to say we're hearing a lot of that these days, and I think it's wonderful that we are. But I wonder sometimes if we're hearing it without really knowing what that means. And Erin, you're the one who teed it up first as saying it's a focus of yours. So I'd love to hear the operational side of that. And I'd also like to understand a little more about whether that's sort of about accessibility, availability, outreach, or is it in program design as well? How do we truly engage those most affected by these policies?
Yeah, and I have to say my thinking recently has shifted in this area, and we are in the beginning stages of really intentionally including a beneficiary voice early, if not prior to policy development, and then as a regularly and like early and often. I think that's an important piece. From an operational perspective, what we've done, particularly in Wisconsin, is again looked at the data, identified communities in particular, and dug down even to specific populations in terms of who has not done, who has, like, what are those marginalized communities, and who has basically a poor relationship with the state, like who's furthest away here. And we've done an application process where it's not like a long application process, but through our community folks, members, people that have, pretty solid networks, have reached out and really brought in a number of parents and caregivers to the table. And basically, we interviewed and spoke to each person and decided we were going to start smaller. So we started out with a group of literally 10 parents, and from all of these walks of life, different experiences. And we have one coach, a person who works directly with each parent. We offer significant stipends. We offer all, technology, so computer, internet, all of those things. We offer childcare. We meet on Saturdays. We do offer childcare, other anything that is causing barriers to doing this work. We will take care of it. And essentially, then we meet and we have parents bring up issues that are relevant in terms of policy, programmatic decisions, and we're starting there. Now you have to go slow to go slow, and it sounds silly, but it's very, very true. To develop relationships, to develop trust, and develop this cohesion of a group that does not know each other. What happens is these members, and we refer to this group as our Parent and Caregiver Equity Advisory Cabinet, they're lifted high. Our First Lady has met with them, our Secretary, etc. They go back into their community and have community conversations to gather more information. They are that trusted community member, and they bring that back. And we have people going with these members into their communities, coming back and supporting them. And there's this back and forth that's happening all across the state to bringing back this information. So we are truly and authentically engaging. Now, is there more work to be done? Absolutely. And we're just starting out, but we have seen shifts in how we are even thinking or what we're even considering as a policy. I think previously you think you know what really somebody needs, but when you actually stop and listen and have these trusted relationships, things change, and my thinking has absolutely changed since forming this group.
Wow, I really appreciate you sharing that. And I just have to say, from when I was in state government, which is now almost 30 years ago, when we thought about consumer engagement or public engagement, we would think you put a person who's a beneficiary of your programs on an advisory council with 20 people. The other 19 are all professional healthcare association folks, and you think, well, we're getting their voice. I'd like to think we did a little better than that, but honestly, that was sort of the thinking. This is a completely different, and it's warms my heart to know that progress has been made. That's I'm going to want to follow your experiment as we go along, and really so glad to hear about that. Other thoughts on, I know CMS has a big focus also on engagement of people who are participating in the programs that you all operate. Obviously 10 people doesn't quite capture the 100+ million people whose lives you touch, but you got to start somewhere. So how do you think about that?
Yeah, a couple thoughts. I completely agree with what Erin said. One of my favorite quotes is, diversity is a seat at the table, inclusion is a voice at the table, and belonging is being listened to at the table. And what Erin's talking about is belonging. And, you know, Alan, I think many organizations, be they state governments, health systems, insurance companies, have these beneficiary advisory panels that are incredibly intimidating environments, right? What you just described of being Medicaid, I mean, everyone on the phone knows this, but Medicaid is a program for low-income individuals. Now imagine being a person with lived experience, which means you are a low-income individual on the Medicaid program, and 19 other people in the room have professional doctorate level degrees. That is an incredibly intimidating environment. And so things like hold the meetings on Saturdays, have interpreters, don't make this person be the only, right, and represent the voices of what is in fact a very diverse group of beneficiaries. Or I think just there's a lot of lessons learned about what not to do. And I think a lot of what Erin described of the operational detail of how you implement reaching into the community and building trust is from those lessons learned. Two other thoughts to maybe sort of underscore. One, that idea of trust. Nothing erodes trust more than asking someone for their input and then not following up with them, right? Not listening to them. And so when our administrator and many of us on the senior team do a number of listening sessions, even something as simple as recapping the feedback that you heard and making a commitment to do something with that feedback, even if what you do with it, by the way, is we heard you, we considered it. Unfortunately, we can't make that change right now, but circling back to the people that gave you that feedback and the people in the community that came forward with whatever vulnerability or bravery that it took to share their opinion is really important, because otherwise, it's another form of exploitation to go into a community, ask for their opinion, and then do nothing with it. And then the second parting thought, I'm curious for Brian's thoughts too, is, and Erin, you mentioned this too, like the idea of local change agents. So in the Medicaid context, for example, for a number of these states that are implementing health-related social needs financing or payment through the Medicaid program to address things like housing instability or nutrition insecurity, having a community-based organization, a community health worker, be the person that connects someone on Medicaid to a social services agency rather than someone from their insurance company is incredibly important and incredibly helpful. You know, the COVID vaccine example that I love, we set up a large, a FEMA-funded community vaccination center, did 3,000 to 4,000 vaccinations a day. And we were able to vaccinate a disproportionate number of individuals from historically marginalized populations like Latinx and Black population because of community health workers who were Spanish speaking only that literally went around the shopping mall with pamphlets telling people, hey, there's a free vaccination site. And that was far more effective than mailings. That was far more effective than our secretary being on the radio or being on TV, but was somebody that spoke Spanish and walked up to someone as they were ordering their lunch in the food court to tell them about a vaccination site. So that's a sort of micro example of a local change agent, but being able to tap into and build trust-based relationships with people who are in the community, and whether it's faith leaders or whoever else, and building a partnership so that really they are the voice and they get to shape whatever the initiative is, as opposed to kind of assuming that the government at whatever level sort of knows what the answer is.
Great. Brian?
Well, I'm just struck and encouraged because these wonderful examples of government at federal and state levels engaging with community is also a parallel process that we're seeing in terms of community engaged research. And so we're moving to a new paradigm where communities are full partners, or at least that's the goal in our research processes, is setting research questions, helping to establish methodologies that are appropriate for the particular communities being studied, advising on how data are collected, who collects it, how, who owns the data, how are data interpreted. These are questions that are being asked at every step of engagement with communities, and it's exciting to see the results, which I think are richer in terms of uncovering the kinds of key questions and issues that our research illuminates. So I think we're seeing a parallel process where partnership produces better results.
That's great. I like how you tie it into the research enterprise as a journal. It's good to think about that as not exclusively about the operational side of this intergovernmental efforts. Well, we're running toward the end of our time. I don't really want you all to generalize too far from the half dozen papers that were presented today. But I am curious if we could close thinking back to the question at the outset about the lessons from there being a general feel from these papers and others that there are positive health benefits associated with the economic interventions that occurred during the pandemic. So whether it's thinking about what we should have in place for the next crisis, or thinking about what should always be in place even when we're not in crisis, completely taking into account Dr. Malik's comment that resources are limited. So just saying, well, we'll continue all of these things indefinitely is probably not a realistic endpoint. So something short of that, what do you draw from this that you hope policymakers will keep in mind as they're thinking about economic policy, given that the health affairs audience is primarily a health policy? Who would like to start closing us out?
I'm happy to start. I think there's, I am quite heartened by the rigor of the research that was presented today that links positive health outcomes to economic interventions. So if I can leave you with only one parting message, it's please keep this up because it's really valuable. It's really hard to argue with facts and rigorously done research when making trade-offs, and policy is all about trade-offs. As looking ahead, I think in addition to my encouragement to keep doing what you're doing, I would say to the extent that it's possible to look at secondary outcomes or longer time horizons as part of your research. I think that is also incredibly helpful. I alluded to this earlier, but even though the pandemic has felt like a lifetime, it's really only been 2.5 years or going on 3 years, right? And I think that there are certain really incredibly important societal impacts that we're going to be studying 10 or 20 years from now. The example I love, and Aaron and I and Brian and I had chatted about this the other day, is things like youth in the juvenile justice system, graduation rates, rates of violent crime, things that we can capture in the short term, but actually were we able to follow a cohort over a much longer period of time, we might actually get very real insight into again, what I'll call secondary or even tertiary outcomes of these policies that might be an unequivocal social good that's hard to capture on a shorter time horizon. So I think, as I said, strong hypothesis in my mind that there are positive health benefits that we have yet to codify or capture or measure. So I think this is, to me, really just the beginning or the tip of the iceberg of what I hope to be a growing body of research.
Great, thank you. Who wants to go next?
I'll jump in, Alan. So for me, the key takeaway may seem trite, but these papers to me, once again, illustrate our interdependence and the fact that that policies that are intended to benefit those most marginalized end up helping all of us at the end of the day. And we've got to take that bigger view. Too often, the American political mindset is one of a limited or finite pie. And we've got to recognize that as we share our resources, as we look at opportunities to help each other, and in particular, during a pandemic, to be squarely focused on the needs of the most vulnerable populations, that's inevitably going to help us all to emerge safer and healthier from the pandemic. And that's a sentiment that I think we've got to do better as researchers, as policy folks, to communicate more broadly. This is not a question of woke ideology. It's about science, and it's about trying to find ways to ensure that we're all able to be safe and recover, and particularly those that are historically the most vulnerable.
I have to say, you both closed this so well, and I absolutely gosh, couldn't agree or say it much better. There's so much going through my head. I will just comment on the policy piece. These papers were fantastic, and I could just bring like bits and pieces throughout that really relate to the experiences I had during the pandemic in terms of making and implementing policy. We're constantly making trade-offs. Always. There's a finite pot of dollars. There's only so much we can do, and we are absolutely including the voices of those with lived experience, but the data to support the decisions that are made, or the decisions to be made, particularly with our legislators, is key. And we don't always have the data like you have shown here. So I just want to encourage you to continue this work. It matters. There will be times I am referencing these papers. I can see it now. Like the wheels are, the connections are happening. The wheels are spinning already. So I just want to thank you for your hard work and your commitment in thinking about these issues, about these policies that benefit children, families, and community members.
Well, those were such great thoughts, and it occurs to me as I try to put those three pieces together. And I'm worried this is going to come out wrong, but that's what happens when you're doing something live. We talked about sort of secondary effects and long-term effects. If you want to live in a community where you're less likely to get COVID, then you want to live in a community where the vaccination rates are higher, and they're higher where there's sick leave for people who would otherwise not have time off to go get vaccinated. You don't want to get COVID from a worker who has to go to work because they're not going to be able to eat or stay in their home even when they're sick, if they don't go to work when they're sick. So we want to make it easier for people to not have to be out and about when they're sick. I hate it. It sounds a little selfish, and that's why I'm a little hesitant to even bring it up. But it's the we're all in it together element of it. We're not all always in it together, and we're certainly not all entering it at the same place. But there are many places and ways in which our fates are interconnected. And some of these policies are not just protective of others, they're protective of ourselves. And even if we don't take advantage of them or need them at the moment. So I appreciate the support for the research as well. Of course, as a journal, we always love people saying that it's valuable and important. And I believe, as all three of you said it, that you mean it and you're giving it additional life. So to the three of you, Brian, Aditi, Aaron, thank you for your thoughts, your comments, your willingness to reflect on the policy context of these papers. And I'll now just bring us to a real close as I encourage our audience to look at the November issue of the journal, where you can read the papers that were discussed today. There's much more there. We have many events, and you see some of them up on the screen. On November 14th at 1 o'clock Eastern, we're preparing for our second thematic issue to be published late 2023 on racism and health, and this will help those who are interested in submitting abstracts. On November 21st, 4 p.m. Eastern, we have a journal club focused on racial and ethnic inequalities in COVID mortality in Texas prisons. And on November 29th at 3 p.m. Eastern, professional development, focusing on writing for our Narrative Matters section, a narrative element of the journal. Access to Journal Club Lunch and Learn and professional developments is to Health Affairs Insiders Only, which is a membership program offering access to content beyond the journal. And it allows us to continue to offer community-wide access to our leading perspectives every day events like this and our digital publication Forefront. Thanks once more to our speakers, both in the opening panel, our authors, as well as our discussion panel. Thank you to the audience. We encourage you to share links to this event after it's posted if you found it interesting. And please come back and see the rest of the work we do here at Health Affairs. And with that, we are adjourned.
Thank you, everyone.